Hello. Hello. Welcome to USMD Step 2 prep. We're just going to quickly go through 9 questions that I have to solve, and then we're going to review them. So this is going to be quick and easy. We're trying to focus on concepts, and the most focus of this session would be on the revision to use the Feynman technique. So let's see. The question here is a 14-year-old boy, his dad had cardiac arrest. Carotid pulse has upstroke. We have to look at that. Strong apical impulse and a faint mid-systolic murmur, best heard at cardiac apex along the left sternal border. Which of the following maneuvers is most likely to increase the murmur intensity in this patient? Murmur intensity in this patient. I'm not sure. It could be squatting, it could be supine leg raising. First, we have to kind of identify what's the pathology here. Mid-systolic murmur. So, AS or MR in systolic. MR more likely. Mitral regurgitation. So, which of the following is going to increase the murmur? So, anything that increases the blood flow through the mitral valve. So, squatting is obviously going to increase preload. I think going to increase afterload too. Leg raise test is yeah, again going to increase both, I think. And I think sustained hand grip is the one which is going to increase it the most. Next. I'm not really sure about this, but this is a classic question that I keep seeing. So, a husband who has abnormal behavior during his sleep, he jerks his hands, legs, and has nightmares. I feel he's too old for Huntington's. If he had obstructive sleep apnea, I doubt it. Seizure, I doubt it. I feel like it's leaning towards Lewy body dementia, so Parkinson's disease. That's why I'm going with that. This recurring question of explosive stools and gas in this baby, I often go towards lactose intolerance because inability to digest lactose leads to an increased amount of ammonia and hydrogen, and the hydrogen causes explosive gases. Let's see some of the questions I got wrong. I sort of don't want to revisit them, so let's just see what happens. I often go back and I fix those answers because I know I would have gotten them right. And at this point, I really need that confidence boost. Right. Some difficult questions that I got right, obviously, I'm very happy about them often. Okay. So let's provide a few very interesting things, flashcards that I keep coming back to. One is the conus medullaris syndrome versus cauda equina. So cauda equina, okay, conus medullaris is upper, so L1, L2. Cauda equina syndrome is lower, L2 to sacrum. So conus medullaris will show low back pain, plus hyperreflexia because it's an upper motor neuron lesion, and perianal numbness. Whereas cauda equina is lower, will show lower motor hyperreflexia, shooting leg pain, and saddle numbness. S1 radiculopathy will show hyperreflexia, lower motor neuron, but no urinary retention or perianal numbness. Okay, so a few very, very interesting topics to recall here. One, conus medullaris. So in this patient, a few topics about Yeah, we already know the concept. So let's just see if we can revise the concept and then go back to this one. So the concept is conus medullaris versus cauda equina. Cauda equina is lower. So conus medullaris is the ending of the spinal cord there, and then cauda equina is just like the nerves. There's no spinal cord. So at conus medullaris is higher. So L1, L2. So here what happens is at conus medullaris, we're going to have hyperreflexia, we're going to have perianal numbness, and we're going to have low back pain. Whereas when we go lower, we're going to have leg pain, we're going to have hyporeflexia, and we're going to have saddle numbness. So that's the main thing. But here again, going back to some interesting this one. So S1 radiculopathy is going to have hyperreflexia with no urinary retention or this one. And we're going to think about some concepts where there's hyperreflex, and you need to be able to differentiate between the two. One is thyroid condition. So we have hyperthyroidism and hypothyroid. In hypothyroidism, we have delayed tendon reflexes and we have hyperreflexia. No, hyperreflexia. Okay. Whereas in cherry red macula, that is Niemann-Pick's and Tay-Sachs. In Tay-Sachs, we have hexoaminidase deficiency leading to hyperreflexia and no organomegaly. Whereas Niemann-Pick, big organomegaly, sphingomyelinase deficiency, and we have hyperreflexia. Tay-Sachs hyperreflexia, sphingomyelinase hyporeflexia. So that's that one. So let's go back to the question here. A 62-year-old male returns to the emergency department due to urinary retention. 2 days ago, the patient was moving furniture when he suddenly developed a sharp shooting pain in the lower back. As soon as sharp shooting pain, we conus equina. Came to this one. He took medication. Um, when patient woke up, he had trained to urinate. Great. Examination of the right lower plantar reflex is impaired. What would you expect here? We would expect hyperreflexia. Perineal sensational decrease. Absent. Yes. So it is cauda equina. Great. Next would be next question is a 34-year-old woman comes to the emergency department. Before that, we can also look at what are the possible questions we can. Okay. So a little extension of one is to differentiate between conus medullaris and cauda equina. So cauda equina is shooting leg. So it is lower motor neuron. So we will have hyporeflexia. And the saddle deformity. Here, very important is the management. So it is MRI followed by surgical decompression. Great. So that is one part of it answered. Next one is here. A 34-year-old woman comes to the emergency department for something. Which of the following is the best next step? So here I was suspecting Wait, comes with a rash and pruritus. She had sore throat. So I was expecting reaction. So I was expecting she had an Epstein-Barr infection, after which she took a penicillin drug and then had urticaria. But what's the answer here? Drug-induced type 1. So, okay, so this is an interesting case of type 1 hypersensitivity, drug-induced type 1 hypersensitivity, type, drug-induced type 1 hypersensitivity. So immediately, drug-induced type 1 hypersensitivity reaction. So if someone takes a drug and has pruritus and urticaria, you think of type 1 drug-induced hypersensitivity reaction. So what happens here is they're previously taken amoxicillin or some other drug, like a penicillin, like a platinum-containing drug, or a quinolone, or a beta-lactam, or a neuromuscular blocking agent. And they develop IgE antibodies, which go and sit on basophils and neutrophils, on mast cells and basophils. And once they're re-exposed to the same allergen, mast cells release histamine. So the management here is antihistamine and discontinuation of the drug. But this is not always the case. Antihistamine and discontinuation of the drug if it's just urticaria and pruritus without systemic pruritus without systemic signs and symptoms. But if it is systemic, then we will use epinephrine and steroids. So systemic would include a respiratory distress, abdominal symptoms, and hypotension, which is absent in this patient. Now, interestingly, there's also infection with Epstein-Barr virus. So you can have an Epstein-Barr infection, then take a penicillin group of drugs and have a maculopapular rash. But here's the thing, that happens after 24 hours. So let's see. So, post Epstein-Barr virus infection, after 24 hours of drug, we have a rash. That's a type 4 hypersensitivity reaction. It doesn't suggest a true drug reaction. Okay, great. So that is next. The next we go is carpal tunnel syndrome in pregnancy. And I feel like I get this wrong so many times. Uh, Syndrome is common during pregnancy. Most patients with mild symptoms respond to nocturnal wrist splinting, which holds the wrist in a neutral position and prevents excessive flexion during sleep. In most cases, it resolves post this one. So, wrist splinting, and it resolves post pregnancy. I think that's all I need to know. But just for some context, so carpal tunnel syndrome can occur due to obesity, pregnancy, diabetes, etc. Uh, Pain and paresthesia in the distribution of the median nerve. Positive Fallon test, Tinel test. Confirmation using nerve conduction studies. Treatment using wrist splinting, glucocorticoid, or surgery. So the patient has hand pain in the distribution of the median nerve consistent with carpal tunnel syndrome. It's common in the third trimester due to hormonal changes and edema. The diagnosis is made on a clinical test. The patient's Fallon test and Tinel test. Tinel is tapping. Light tap elicits tingling. TTT. And phalanx test is flexion of the wrist compresses nerve inside the carpal tunnel. Phalanx compressions. Most patients with mild carpal tunnel respond to conservatives such as nocturnal wrist splinting. Splinting holds the wrist in a neutral position and prevents excessive flexion during sleep, lowering pressure within the tunnel. In most cases, carpal tunnel syndrome resolves spontaneously after childbirth. Okay, so carpal tunnel first is wrist splinting. If it doesn't work, then we go for glucocorticoids, local, and then that doesn't work, we go for surgical decompression. Okay, interesting. So let's go with carpal tunnel again. Yeah, and so interesting. We have the Fallon Illuminati compression test and the Tinel tap tingling test. Can be seen in rheumatoid arthritis, can be seen in carpal tunnel in pregnancy. It's seen in end-stage renal disease, hypothyroidism, pregnancy. can be seen in pressing down hard. So pregnancy, dialysis, hypothyroidism, acromegaly, rheumatoid arthritis, and diabetes. Yeah, so push down hard is push down hard, and then same thing. So we have splinting, local steroids, topical steroids, and then we have surgery. Okay, great. So that was carpal tunnel. The next we go to is yes, love psychiatric questions because I'm bad at it. Let's go. Young children often prefer particular foods or groups, which is consistent with normal development. However, when picky eating is accompanied by behavioral rigidity, poor growth, weight loss, further evaluation is necessary. So this was relatively hard for me even back then because what puts me off in this explanation is that she makes eye contact, but then when asked about her food, she's answering something else, right? She's talking about owls. So although this child has specific food preferences, she generally eats a variety of foods and is tracking adequately on growth curves. Young children often have certain preference for individual foods or food groups. This, together with a growing sense of autonomy, may result in picky eating, which can manifest as preference for certain foods, offering a child a variety. If there is rigid behavior or poor growth or weight loss, then further investigation is needed, which doesn't seem to be the case. Which the patient does not display. Okay. And then obsessive. Right. So picky eating and okay. So picky eating is normal behavior. That's all I know. Okay. Picky eating is normal development. That's what I gathered from this. So picky eating is normal behavior unless it is accompanied by, unless there is developmental delay or weight loss, etc. Great. So that is that. What's the next thing? Yeah, hepatocellular carcinoma. So this person comes with bloody ascites, and that's the most striking feature in the question stem. Figuring out what that means. So it appears that the only reason for bloody ascites is hepatocellular carcinoma. So we'll just write that down. I think we can take a quick break and then do the rest of the questions.